So today my topic of discussion is echocardiographic assessment, pre and post valve replacement. Thank you very much firstly to the organizers of EZECHO for inviting me for deliberation of this topic. And though it's a very big topic, I'll try to very briefly summarize the the important points within a very short span of time and the important clinical caveats, mainly through small videos and illustrations. And because pre-valve evaluation is separate assessment altogether, I will mainly focusing on the post-valve replacement assessment, echocardiographic assessment, both TTE as well as some TE images which are pertinent to certain cases. Regarding pre-valve replacement, I'll mainly focus on the emerging role of echo prior to TAVR. So it's important prior to TAVR because first to establish the indications of TAVR, that is the severity of aortic stenosis, the subtype of aortic stenosis, whether it is a high gradient or low gradient, assess the LV ejection fraction, and assist in the TAVR valve sizing. All these things has been discussed by Orono already. So what to look for during TAVR on echo? During TAVR, we have to look for the TAVR valve function, whether there is any paravalvular leak immediately after the valve implantation, and immediate development of any complications in the form of impingement onto the coronary ostium or valve slippage within the LV cavity. However, intra-procedural echo evaluation is also important, which is mainly done through transesophageal echocardiography, whether proper pre-procedural valve sizing is done, and when newer generation valves or self-expanding valves are used by an experienced TAVR team, usually it is uneventful and complications are rare. And markers of good implantation that we have to see in TAVR is firstly the valve shape and the location of the valve. In short axis, after implantation of the valve should look circular rather than ovoid. Ovoid valve shape after TAVR is a marker of suboptimal valve dilatation. And in long axis, the proximal end of the valve should be just a few millimeters, maximum up to 2 to 4 millimeters within the LVOT. If it protrudes more into the LVOT, there is more chances of slippage of the valve into the LV cavity, or unstable positioning of the valve that may require repositioning. Also, after proper valve implantation, the maximal gradient should be less than 2 meters per second, and there should not be any significant paravalvular, transvalvular aortic regurgitation immediately after the valve implantation. So these are the markers of a optimal TAVR valve implantation. And if one or more of these points are suboptimal, we should consider repositioning of the TAVR valves for self-expanding valves, post-dilatation of the valve with a balloon, or implantation of another TAVR in bailout cases. Now, more important is how to assess the prosthetic valve function. And in this discussion, I'll mainly discuss how to assess the prosthetic valve function briefly, what are the important parameters that needs to be assessed and should be looked for, and some echo images of important patients who had undergone prosthetic valve implantation. Now, the timing that is recommended by ACC/AHA guideline is 6 weeks to 3 months after valve implantation. A detailed echocardiographic examination should be done to allow the assessment of the effects and the results of the surgery. It also serves as a baseline for comparison should complications or deterioration occur later. So these echocardiographic assessment is very important to compare later on. And no further echocardiographic testing is usually required after the initial postoperative evaluation in patients with mechanical valve, unless it is not required in the patients who are stable, who do not have any symptoms of valvular regurgitation, and no clinical evidence of any prosthetic or ventricular dysfunction or dysfunction of other heart valves. Timing of assessment of the prosthetic valve: usually another initial transthoracic echo is recommended after prosthetic valve implantation for evaluation of the valve hemodynamics, and it is required in the patients with prosthetic valve if there is a change in clinical symptoms and signs that suggest valve implantation. In that case, immediate echocardiographic assessment will be required, and transesophageal echo is recommended when clinical symptoms suggest prosthetic valve dysfunction. An annual TT is reasonable in patients with a bioprosthetic valve after the first 10 years, even in the absence of change in the clinical status, because after 10 years, as we all know, the chances of valve degeneration in the case of bioprosthetic valve increases. And important points while imaging the valve: we should look for the motion of the leaflets or the occluder, presence of any calcification, pannus on the leaflets, any abnormal densities, which can either be thrombosis or pannus on the various components of the prosthesis, and also the sewing ring integrity and the motion of the valve, which is very important. Few Doppler parameters that should be routinely assessed while study of the Doppler study of a prosthetic valve is the contour of the jet velocity signal. It's a very rapid and early assessment functioning and whether there is any thrombosis or obstruction in the valve flow. The VTI of the jet, Doppler velocity index, that is also an important parameter for the assessment of mainly aortic valve obstruction after valve implantation. Pressure half time in mitral and tricuspid valve, effective area, effective orifice area, and also presence, the location and the severity of regurgitation, which is very, very important in case of any prosthetic valve, because it is usually a dictum that any degree of regurgitation after a prosthetic valve implantation should be considered pathologic unless proven otherwise. So these are the basic parameters that all echocardiographic echocardiograpers should be well acquainted with, and it should be mentioned in the detailed echo report, particularly in the first report after prosthetic valve implantation. So coming to another case, a simple case of post MVR where St. Jude's mitral valve was implanted 2 years back in a 27-year-old female, that shows a normally functioning prosthetic valve. It is just to show how a normally functioning prosthetic valve looks like. Beautiful motion of the bileaflet valve is St. Jude's mitral valve. The Doppler study shows and the closing click, which is sharp, that indicates brisk opening and closure of the mitral valve leaflets that corresponds with the opening and closing clicks in the auscultation also. The peak and the mean PG is also within normal limits. The mitral valve area as measured from the pressure half time equal to 3.6 centimeters square. That is pretty normal. 3D echo of a normal St. Jude's valve shown from the perspective of the left atrium. You can beautifully see the motion of these two leaflets in 3D echo also from the left atrial orifice. Now, these are the Doppler parameters while assessing prosthetic mitral valve function. I'm not going to details of this because we all know it is available in all the textbook, the standard textbook. That is, we should look for particularly for severity of the stenosis. Mean gradient is an important parameter. If it is more than 10 in any prosthetic mitral valve, we should think about mitral valve thrombosis, and immediate clinical assessment or clinical intervention should be done. Also, assessment of pressure half time, which if more than 200, or peak velocity if it is more than 2.5 in a prosthetic mitral valve, should raise the suspicion of mitral valve prosthesis. Next, coming to a post AVR patient, 35-year with a St. Jude's valve done 5 years back, that shows a normally functioning prosthetic St. Jude's valve. One important point is that in a patient who has been implanted with a St. Jude's, prosthetic aortic valve, the walls of the aortic root is often obscured by the motion of the disc. So the walls of the aortic root may not be very clearly visible. This is an important point. Second, another important point is that St. Jude's valve creates a reverberation, a pattern of reverberation that extends onto the left atrium. This is a reverberation that is extending onto the left atrium in 2D view that can obscure the presence of MR on Doppler study. So it can underestimate the presence of MR in presence of a St. Jude's valve and these reverberations. So this is an important clinical caveat that has to be kept in mind. Another important point is to differentiate between pannus and thrombus in an implanted valve. As we all know that pannus is usually fibrous and it is usually annular in location, more peripherally located, and because it is fibrous, it is more echogenic. So typically presenting as a very dense and immobile echo, pannus are typically seen in the patients with normal anticoagulation profile and subacute or chronic symptoms. And pannus formation is more frequent on the aortic valve than on the mitral valve. If at all, if it is on the mitral prosthetic valves, more often they occur on the atrial side of the prosthesis rather on the ventricular side of the prosthesis. So these are the important clinical clues to differentiate between pannus and thrombus, that pannus will be more echogenic, it will be more peripherally located, it's usually more common on the aortic valve, it is usually immobile, and it's common in patients even with a normal anticoagulation profile, and patients will have a very subacute symptom ranging from weeks to months, whereas a patient of valve thrombosis will be a very fulminant presentation with acute left ventricular failure or left atrial failure, as we all know. So these are the clinical clues as well as echocardiographic clues to differentiate between the two things. This is an pictorial demonstration that how a pannus will progress. It will be a small mass growing from within the suture line along the plane of the valve, whereas a thrombus will be a large, because it is blood clot, so it will be less dense on echocardiography, and a mass which is projecting away from the valve disc. So these are the clues to differentiate between the things. It's a beautiful pannus detected on autopsy, that how it grows along the sewing ring and along the valve leaflets, and highly echogenic mass, and corresponds to the pannus pathology of pannus at the surgery. Next is valve thrombosis. We can see a big thrombus within the mitral valve prosthesis, whereas the mean gradient was 12. This is acute presentation. Patient presented as acute left atrial failure, pulmonary edema. And after immediate thrombolysis, how the thrombus has dissolved and the mean gradient has reduced from 12 to 4. So this is, dramatic results with proper diagnosis of mitral valve thrombosis, and how a long duration of streptokinase infusion, as we all use in our clinical practice, where urgent surgical facility may not be feasible at all the times. Urgent thrombolysis for a prolonged duration can resolve the thrombus completely and reduce the mean gradient across the valve. This is another example of a large thrombus visualized on the left atrial aspect of a mitral thrombosis. This is a big thrombus that is visible on transthoracic echo, mobile thrombus that is moving on the mitral valve leaflets. This is a transesophageal image of the same patient. We can see two big thrombus within the just above, residing just above the prosthetic mitral valve. So how it looks like a lesser echogenic mass, mobile mass, and projecting or protruding into the lumen, whereas pannus will be more firmly adherent to the annulus. Next, I'll give an example of a primary tissue degeneration of a porcine mitral valve. As more and more bioprosthetic valves are used in day-to-day practice, we should have a idea regarding how a bioprosthetic valve degeneration looks like in a 2D image. It will be the valve leaflets will become thickened and fibrosed with decreased mobility, and we give a Doppler, colored Doppler image, we can see the valvular regurgitation. So thickened, fibrotic, and less mobile indication of a primary tissue degeneration of a porcine valve. Another example, an echo-free space anterior to aortic annulus. As we can see, this echo-free space, this is the echo-free space anterior to the aortic annulus. Color Doppler shows a perivalvular regurgitation from the aortic root to the LVOT. So this is a perivalvular regurgitation in a patient who underwent an aortic valve leaflet. In 2D image, it might just look like that of a small out or echo-free space. Anterior echo-free, the same patient in PSAX image, in short axis image, these anterior echo-free space, as we can see in the video, is indicator of the valve dehiscence, and color Doppler shows the same is confirmed by color Doppler where there is flow. Transthoracic echo can be deceptive at times. The left image shows transthoracic echocardiogram of a prosthetic mitral valve, where it is showing the transthoracic echo showing only a mild mitral regurgitation, but the patient presenting with symptoms of acute LVF. Whereas the esophageal echo in the same patient on a different view shows a huge severity of mitral regurgitation on the color Doppler. So we have to corroborate not only by echocardiography but also by the clinical presentation of the patient. I am not going into the parameters of transthoracic echocardiographic findings. It is, provided we all know it. These are the echocardiographic Doppler criteria of prosthetic mitral regurgitation, almost the same as that of normal or native mitral valve, same as for aortic mitral valve. So this is a prosthetic mitral valve velocity at the level of valve. Aortic valve, it is 2 meters per second, whereas the LVOT velocity at the level of LVOT is 1 meter per second. From these two velocities, if you can calculate the velocity at the aortic valve and the LVOT level, we can calculate this Doppler velocity index, that is also an important indicator of stenosis of the valve. So it's a very simple dimensionless index, that is the proximal velocity and the LVOT tract to that of the velocity through the prosthetic valve. If in a case of normal prosthetic valve function, the mean velocity, Doppler velocity index ranges around 0.4 and with a range of between 0.28 to 0.55. A Doppler velocity index of less than 0.25, that is whereas the the velocity across the prosthetic valve is increased, the denominator is increased, so the value will diminish less than 0.25, which is highly suggestive of significant valvular obstruction. This is a simplified algorithm, that is with a DVI of less than 0.25 and with acceleration time of less than 100. This typical triangular type of configuration, this usually indicates an improper LVOT velocity timing, because it should be like this typical circular type with an acceleration time of more than 100, that indicates a significant prosthetic aortic valve stenosis. So the combination of these two with an acceleration time of more than 100 across the valve and Doppler velocity index less than 2.5 usually indicates a severe prosthetic valve stenosis. So another case, this patient developed fever approximately 1 month after aortic valve replacement. So let's see what the echo shows. It's actually a mycotic aneurysm that developed as a result of abscess formation just adjacent to the sewing ring. So that is the classical site of aortic root abscess formation. And Doppler shows, this is the short axis image, sorry, the same, this dehiscence, there is a root abscess formation. Flow through the aneurysm into the RV can be seen. This is a Doppler flow. Often a combination of TTE and TE is often necessary. This is a example of that large mass was recorded in the LA during transesophageal echo, which was unable to be identified during transthoracic echo in case of a St. Jude's mitral valve implantation. So this is a transthoracic echo. We cannot see the LA mass very clearly, whereas in transthoracic esophageal echo, large mobile mass can be clearly seen. So at times, as I have already told, that a combination of transthoracic and transesophageal echo may be required in many cases. This is another Doppler study that shows this excessive movement of a dehiscent prosthetic valve. You can see in 2D, the excessive mobility of the dehiscent valve can be seen. This is another example of a severely dehiscent of a porcine aortic prosthesis. Prosthetic valve motion independent of the aortic valve root motion can be seen. So this is a movement of the porcine aortic valve that is moving independent of the aortic root, and also in Doppler that showed significant perivalvular regurgitation. Another patient who underwent aortic root and aortic valve as well as root replacement for endocarditis. 1 month after surgery, the patient presented with fever and heart failure. Transesophageal echo showed markedly dilated aortic root with complete dehiscence of the aortic valve. So the hugely dilated aortic root, we can see the aortic valve has been completely separated from the aortic root, and the portion of a prosthetic aortic root can be seen within the dilated native aorta. So this prosthetic aortic valve and the prosthetic aortic root, the entire thing has been separated from the native aortic root, and this highly mobile mass, this mass is consistent with the vegetation, this highly mobile mass. So these are the things that we have to keep in mind. Patient prosthetic mismatch, as we all know, always to be kept in mind. Actually, it's a non-structural dysfunction. It's actually composite category that includes any abnormality that results in functional stenosis or regurgitation of the operated valve that is not intrinsic to the valve itself, exclusive of thrombosis or infection. So it includes inappropriate sizing, and when the effective prosthetic valve area after insertion into the patient is less than that of the native valve, it is then also called the patient prosthetic mismatch. And patients with aortic prosthetic valve had obstruction to the LV outflow similar to aortic stenosis, and patients with mitral prosthetic valve had obstruction to the left atrial emptying similar to mitral stenosis. So all these together falls into the category of patient prosthetic mismatch. So it is not only undersizing, but also the other factors also that can be kept into the same category. These are the threshold values for index prosthetic valve effective orifice area. This is a pulmonary homograph that shows increased velocity. This is a normal transvalvular gradient of 1.8 and increased gradient of 4, showing dilated left ventricle, obstructed pulmonary homograph. So thank you very much. This was all about my presentation.